Is Reverend Dr. Lakeisha Cook, and I am the co-executive director of Virginia Interfaith Center for Public Policy. We would like to thank all of you for your presence today at this press event highlighting the findings of a recent Department of Medical Assistance Services study called the Prenatal Secret Shopper Survey as part of the 2023 External Quality Review and Technical Report. This survey, which revealed that a majority of prenatal care providers who are enrolled with the Virginia Medicaid MCOs that were contacted by a secret shopper did not provide adequate services when they were contracted to provide. During the study, the secret shopper, posing as an enrolled patient seeking care, had trouble accessing care. According to the report, in 95% of overall cases, providers were unable to be reached, did not offer prenatal care services, were not at the sampled location, did not accept the requested MCO, did not accept Virginia Medicaid, were not accepting new patients, or were unable to offer an appointment date. As a Black mother, I am deeply disturbed and concerned by these findings. It is unimaginable that people across the Commonwealth who need prenatal and maternal health care cannot receive adequate services from providers receiving state resources. I remember what it felt as a first-time mom, how anxious I felt during my pregnancy, concerned about the health of my child, worried about my own health as I struggled with blood pressure issues. One of the things that provided some much-needed relief was access to adequate health care. It helped ease my concern tremendously to have a healthcare provider that I could call at any time with questions and schedule appointments with relative ease. It sickens me to think what it must feel like being pregnant, dealing with the anxieties that come along with pregnancy, getting a referral to a place that should provide care, only to be faced with multiple obstacles. Instead of easing anxieties, the stress of these new patients and new parents often becomes compounded. As a faith leader in Virginia, I believe that we can do better. I actually know we can do better. We are imploring state lawmakers and the governor to provide DMAS with the tools and resources they need to hold Virginia Medicaid managed care organizations accountable. An important part of the accountability that we are proposing is for the Virginia Medicaid managed care organizations to report publicly on a monthly basis how they plan to partner with community-based organizations to address barriers to assessing maternal and infant health care. Along with accountability, it is imperative that we continue to create policies in Virginia that assist in providing the best possible maternal health care services. It is also equally important that we create policies that directly address the racial disparities in maternal and infant mortality. In Virginia, Black women have a 2.3-fold higher rate of pregnancy-associated mortality compared with white women, even when controlling for confounding factors such as socioeconomic or education status. In Richmond, infants born to Black women die at a rate of 1.5 to 3 times more when compared with other races. We appreciate the acknowledgement of Governor Youngkin and the Virginia General Assembly regarding the racial disparities in maternal and infant mortality. It is difficult to heal and repair what we refuse to acknowledge. We continue to be hopeful that we can move beyond just acknowledgement to more accountability and action. I am honored to be able to share this time and this day with so many wonderful activists and social justice warriors. And it is my honor to introduce the next speaker this morning, an activist that I'm honored to work beside every single day at Virginia Interfaith Center for Public Policy, Catherine Haynes, who is the Health Equity Manager of Virginia Interfaith Center for Public Policy.
Good morning. In 2019, the Virginia Interfaith Center for Public Policy Health Equity Manager Dora Muhammad launched the Push Maternal Health campaign to achieve the goal of eliminating racial disparities in maternal and infant mortality and making maternal health care equitable to all within the Commonwealth. Over the past 4 years, the campaign has grown into a coalition of more than 20 organizations and faith leaders committed to advocating for equity in maternal health. As a former licensed Virginia midwife and a mom of 4, it is an honor to work alongside so many folks that understand we have work to do. Virginia moms, pregnant individuals, children, and families are counting on us. We are here today, as Reverend Cook discussed, to talk about the Prenatal Secret Shopper Survey and the opportunity that it provides to advance policy priorities that will expand access to equitable maternal health. I need to acknowledge that according to a VPM article published this morning by Henry Brannon titled Data, Virginia Medicaid's Managed Care Failing to Connect Patients with Prenatal Care, that there is a mistake in the methodology reported for the secret shopper surveys in the mentioned report. This does not invalidate the data, and the VPM article goes on to say that the providers and advocates anecdotally confirm the survey. PUSH Coalition members also confirm problems with the lack of access to care. I want to thank DMAS for making the Secret Shopper Survey report publicly available. Transparency is courageous and leads to better policymaking. PUSH Coalition members were not surprised by the contents of this report. Many of us work directly with the families that are impacted by a lack of access to care, some of whom will speak today. Their experiences, as well as our personal experiences, such as those shared by Reverend Dr. Cook, fuel the passion that keeps us in the fight for better access to quality care for all. We are familiar with the data illustrating the lack of access. According to state available data, in 2022, the West Piedmont Health District reported a maternal mortality rate of 591.72 per 100,000 for the Black non-Hispanic population and 0 for the white non-Hispanic population in that same category. According to VDH data, Henry County, located within the West Piedmont Health District, had a Medicaid birth percentage of 72.5% in 2022. The percent of women with late or no prenatal care for the Black non-Hispanic population in the West Piedmont Health District is 8.1%, which is more than 2.5 times the 2.9% of pregnant women with late or no prenatal care for the white non-Hispanic population in that district. PUSH Coalition members are here today to provide their expert perspective. They will respond to the results of the Secret Shopper Survey and make a connection between those results and the policy solutions for which we as a coalition advocate. Policy solutions that, along with support for DMAS, will help drive change. You will hear from Nicole Wardlaw, the midwife representing the Virginia affiliate of the American College of Nurse Midwives, Stephanie Spencer, founder and executive director of Urban Baby Beginnings, Victoria Richardson, staff attorney for the Virginia Poverty Law Center, Emily Moore, senior policy analyst, Voices for Virginia Children, Freddie Mejia, the policy director for the Commonwealth Institute and the lead for the Healthcare for All Virginians, or HAVE Coalition, and Kenda Sutton L., the founder and executive director of Birth in Color. I will wrap up the conference with PUSH Coalition demands, and there will be time for a Q&A. Nicole Wardlaw, midwife representing the Virginia affiliate of the American College of Nurse Midwives today. The mic is yours.
Good morning. So I am Nicole Wardlaw, and I'm a Black midwife. I represent the Virginia affiliate of the American College of Nurse Midwives, but I'm also representing the National Black Midwives Alliance. I led this by saying that I'm a Black midwife because I know firsthand what it's like in my community. I have experienced the bias when I was pregnant. I have daughters that I don't want them to experience the same bias that I experienced when I became pregnant. And I became a midwife because of what happened to me during my pregnancy. I also received the phone calls of clients that are dying to transfer into my practice because they don't feel seen or heard. They feel like they're a number. They feel like no one's listening to them. They tell their providers about what's happening with them, and they also are not heard. It's dismissed, and that is why we are having the disparities that we have in our community. I also want to add that out-of-hospital births have increased for Black women. Why? Because they're afraid to go into the system that's not listening to them. They're afraid because they think they're going to die in the hospital. So they would rather have an unassisted birth at home instead of going into the hospital. So it's midwives that are trying to be the go-between between the system and the community to say, no, this is a safe option. No, you're gonna be fine. But we can't give them promises when they're in a system that's not listening to them. Implicit bias training is a legislative priority. I'm gonna say that again. Implicit bias training is a legislative priority. We all have biases, right? When I stepped up to this podium, I'm sure there were biases about me. Who is she? What makes her qualified, right? If you see me on the street, you would have no idea about whatever credentials I may hold, right? And when I see each of you, I may have biases about you. I don't know who you are. I don't know anything about you, but I do have preconceived notions based on how you're raised, what exposure you may have, right? But I will say that even, going in the hospital system, people have thought that I was environmental, right? They've like, oh, you're the housekeeper, or maybe you're the patient care tech. I'm like, well, no, I'm the provider. They're like, oh, you're the provider? Well, who are you working with? Is there a doctor there to back you up, right? And the doctor that's backing me up may have been a new resident that just came out. I have 19 years of experience. And so I always tell clients, if that's who you want to be your provider, you're more than welcome to have them. That's fine. They're qualified, but that bias is definitely there. But also imagine the patients that come into a practice, they're vulnerable with their pregnancy and at the mercy of their providers. And if she is a Black woman, there's this automatic assumption that she's uneducated and she must be single. They don't see the Black families, the whole unit. They see Black women, uneducated, single, right? If you have to compare, you have large families, right? A white family comes in, they have 8 kids. Oh, that's a nice family. A Black woman and her husband come in, they have 8 kids. Why do they have so many children? Why are they repopulating, right? So those biases are definitely there. Having this training makes us realize what our biases are and how to better address them. I applaud the new proposed MCO contracts for including implicit bias training and adding access to midwives and doulas. A recent report using secret shoppers came out stating that clients were having difficulty getting access to care. And of course, we know that early access has proven to reduce poor outcomes. But when these clients finally come into care, they should have providers that not only understand their personal biases, but have addressed them prior to giving care in these communities. Even alcoholics and other substance abusers have to acknowledge there's a problem before they can get help. So providers have to realize their biases before they can address the problem. We want our outcomes, especially in the Black community, to improve, and it will not improve until people realize what their problem is. Thank you. Stephanie, the floor is yours.
Good morning. Thank you for the opportunity to speak. My name is Stephanie Spencer. I'm the Executive Director and founder of Urban Baby Beginnings. Our organization is dedicated to improving maternal and infant health outcomes in Virginia through the use of our maternal health hubs. My family, like many in Virginia, have experienced infant loss and harm in systems that were meant to protect us. And I'm here today because, like everyone in this room, I care about Virginia's moms and babies and the future of our Commonwealth. Recently, the governor issued an executive order to reestablish the Maternal Health Data Task Force in Virginia. This initiative is a crucial step towards understanding and enhancing the health policies that affect mothers and infants through our Commonwealth. At Urban Baby Beginnings, we see firsthand the challenges families face in accessing the necessary support for prenatal care, social services, and mental health needs, and the outcomes when they cannot find quality care and services. Urban Baby Beginnings is in full support of this task force and the work ahead of us, and we'd like to thank Governor Youngkin and his administration for his commitment and their commitment to addressing maternal health disparities in Virginia and issuing this important order. One of our key initiatives at Urban Baby Beginnings is to engage doulas, community health workers, health systems, and providers such as midwives and OBs across the state, ensuring that mothers have access to community support and that can significantly improve their health outcomes. When this journey started, we spoke with many mothers across the state, and many of you all followed along on that journey, gaining feedback about their challenges and needs, which focused on quality care and access, wraparound services, crisis intervention, mental health support, and more. It was important that we reflected their voices in this work. Elevating community voices remains our top priority and our concern, and we represent the mothers who could not be here today. We've also watched and supported the governor's administration, DMAS and others, enacting legislation to expand Medicaid, extend postpartum coverage, giving mothers access to needed services that were previously cut off at 60 days postpartum. We've collaborated with the governor's administration, DMAS, managed care organizations, various state and federal partners who share our commitment to doing more for our maternal families. We've also stood by our families as they navigate unfamiliar terrain during their pregnancy and recovery, all while they love on their babies. Even with this joy and challenge, there is still much to be done. During a survey of moms and community, respondents indicated that they had trouble with connecting to needed services. Many of you may have also experienced the same. It's just something that we don't talk about, that we accept, because it's how the system is built today. But that does not change the fact that these services are critical for the health of our moms and our babies. And we know that strengthening support at the ground level through strong partnerships with Virginia managed care organizations, commercial insurance plans, community-based organizations, the state, and others can help make Virginia the safest place to live and raise a healthy and thriving family. Our commitment is to honor the promises to our families, a promise that states regardless of a mother's financial ability, during pregnancy, postpartum recovery, and their baby's first crucial years, that they have a safe place to go in the community to get the help and services that they need. UVB's maternal health hubs are a model that can be replicated across the state, and with federal and state support will help mothers and babies get the care they deserve. Care such as care coordinators, doulas, connections to managed care organizations, health education, resource navigation with community health workers, and integrated care with maternal health providers and hospital systems, thus helping us to eliminate this disparity that we see today in connections to prenatal care and services. Care that ensures that no mom or baby is left behind. We are here today to ask DMAS and the General Assembly to support legislation to support the hub model, its evaluation and expansion. We are also asking for a budget allocation to support data sharing agreements between perinatal health hubs and community-based organizations. These community-based organizations are already collecting critical data and access to doulas, midwives, and community health workers. Our call to action is that we strengthen our system of care so that moms, babies, grandparents, kinship families, and others have a safe place that specializes in connections and care to services, while also providing direct support through the use of our care coordinators, doulas, midwives, and more. And that starts with ensuring that families have access to a maternal health hub in their locale. With a committed administration and dedicated partners, we really have a unique opportunity to continue to make a significant impact on maternal and infant health. By securing this funding and support, we can ensure that our families receive the comprehensive care that they deserve. We would like to thank the Governor's Administration, DMAS, our managed care organizations, community, for the work that they have done and achieved together. It has been many years that we have traveled along this path together. There's still a lot of work that needs to be done. Obviously, this survey shows that we need to do better. One of the things I know is that we're committed to doing that, and I would like to thank the Commonwealth for what they will do next as we continue to support our mothers. I would like to introduce our next speaker, Victoria Richardson, Staff Attorney, Virginia Poverty Law Center.
Good morning, everyone. The results of the Secret Shopper Survey are devastating. Out of 1,844 cases, 95% of callers were unable to successfully schedule appointments. Moreover, of those that were able to schedule appointments, The average wait times for the first, second, and third trimester appointments were 14, 13, and 17 calendar days, respectively. Imagine having to wait 17 days for a third trimester appointment. This is too long to wait for prenatal care, according to both accepted medical standards and DMAS's own standards. I now want to turn your attention to another DMAS guideline for pregnant women. According to the Medicaid Eligibility Manual, applications for medical assistance are supposed to be processed within 7 days when the applicant is pregnant. Our navigators at BPLC are seeing applications delayed far past this deadline, which results in inadequate prenatal care for our clients and unnecessary stress for their families. Another report performed by the same group that did the Secret Shopper Survey, the Health Services Advisory Group, addresses the 2022 through 2023 contract years. And it indicated that pregnant women who are new to Medicaid and famous often wait up to 45 days before their applications are processed, and they cannot access their benefits during this time. This information, combined with these Secret Shopper Survey results, helps explain the striking disparities in prenatal care throughout the state. 16.7% of births among Black women and 25.8% of births among Hispanic women on medical assistance had inadequate or sometimes no prenatal care. 30.5% of mothers enrolled in Famous Prenatal had inadequate or no prenatal care, and this was the worst performing of all the medical assistance programs in the state. And by region, the northern Winchester region actually performed the worst, with only 65.1% of women receiving adequate prenatal care. And then the Tidewater, Charlottesville, and Roanoke regions also performed below the national benchmark of 76.4% receiving adequate prenatal care. Given the obvious risks to the health and safety of these mothers and their babies, we must act now. BPLC and the PUSH Coalition propose that DMAS move forward with a recommendation of the 2023 Task Force on Maternal Health Data and Quality Measures to expand benefit coverage to include presumptive eligibility for ambulatory prenatal care. This policy would allow qualified entities such as community health centers and other healthcare providers to do a preliminary screening for eligibility for medical assistance. And this would allow pregnant women to access their prenatal care immediately without having to wait on local DSS offices to process their applications. This coverage would last for 60 days and would provide more comprehensive coverage than what already exists with hospital presumptive eligibility, which only lasts for 30 days and can only be used for one period per pregnancy. The pregnant individual would have 60 days from the date that eligibility begins to complete her application, and this policy would relieve some of the administrative burden on local DSS offices, who are already struggling to keep up with their caseloads and retain employees. This is not a new policy either. 30 states already use presumptive eligibility for pregnant women, meaning that Virginia is actually within the minority of states that do not already have this policy in place. Furthermore, this would not be an expansion of eligibility. It's just an easier and quicker way to ensure that pregnant women who are already presumably eligible can access their benefits earlier. Considering how long it takes covered women to schedule appointments for prenatal care, based on the Secret Shopper Survey, instituting this policy is urgently needed. Next speaking will be Emily Moore from Virginia Voices for Children. Thank you.
Good morning. My name is Emily Moore, Senior Policy Analyst at Voices for Virginia's Children. Voices is the Commonwealth's only independent, multi-issue child policy and advocacy organization and a member of the PUSH Coalition. The results of the Secret Shopper Survey require us to pause and consider how we can collectively work together to ensure that Medicaid members receive timely, high-quality perinatal care before, during, and after their pregnancy. Research shows that having stable health coverage during the perinatal period improves maternal and infant health outcomes throughout their lives. But having health coverage isn't always enough to guarantee access to and continuity of care. Many aspects of our healthcare system can also decrease access to care and present significant barriers to seeking and receiving care, such as lack of available providers, waiting time for available appointments, and travel time and accessible transportation options to get to those appointments. Even with increased maternal care coverage, access to maternity hospitals, birth centers, and providers is heavily impacted by geography. The March of Dimes reported that in Virginia, 31% of counties are defined as maternity care deserts, and 15% of birthing people had no birth hospital within 30 minutes from their locality. Voices in the PUSH Coalition support the following policy solutions to improve access to perinatal health care. First, we must invest in the recruitment and retention of a diverse and culturally reflective workforce. Community health workers are public health professionals whose lived expertise helps patients navigate healthcare and social services systems. The survey recommends improving the accuracy of provider information available by considering the health literacy of the population served. We know that our community health workers routinely support the health literacy of the community members that they work with through advocacy, education, and outreach. Current budgetary funding for community health workers requires that funds are prioritized for local health districts that serve localities with the highest rates of maternal mortality. We must work towards sustainable financing of community health workers through a Medicaid benefit to ensure access across the entire Commonwealth. Second, we must streamline Medicaid coverage through continuous eligibility policies to improve access to care. Continuous coverage provisions during the COVID public health emergency ensured that pregnant individuals and children didn't face disruptions to their coverage, thus improving their outcomes by reducing birth complications, providing mental health support services, and accessing lactation support. Virginians have benefited from 12 months of continuous postpartum coverage. The 2022-2023 Medicaid and CHIP Maternal and Child Health Focus Study reported that members who were continuously enrolled for more than 180 days had higher rates of postpartum outpatient care utilization as opposed to emergency department utilization. Ensuring continuous coverage for children can serve as an additional support for their parents during the postpartum period and beyond. Virginia currently allows caregiver depression screenings at well child visits at a pediatrician, a critical support for parents during their postpartum. We have to go a step further and facilitate continuity of care by establishing multi-year continuous eligibility through Medicaid and CHIP for children birth to 6 years old. Well child visits often serve as a perinatal health touch point for parents, and pediatricians have long recognized the importance of the two-generation approach to providing care for children and their families. If we want a Virginia where all families can thrive, we have to start with perinatal health. Lawmakers in DMASC must fully leverage Medicaid funding for perinatal health care and prioritize the data collection and sharing to document our progress in areas for needed improvement. Our families deserve nothing less. I would now like to welcome Freddie Mejia, the Policy Director at the Commonwealth Institute, to the podium. Thank you.
Good morning. All right. Thank you, first off, to the PUSH Coalition for the invitation to speak today. My name is Freddie Mejia, and I lead the Healthcare for All Virginians Coalition. The coalition brings dozens of Virginia-based nonprofits, advocacy organizations, and other health policy stakeholders together to advocate for one common goal: expanding access and eligibility to health coverage for everyone in Virginia. In recent years, we have applauded maternal health investments in Virginia's Medicaid and CHIP programs, which remove barriers to coverage for pregnant immigrants who call Virginia home, and have also expanded services available to pregnant individuals. It was our good faith assumption that thousands of people would be able to access timely health services with the coverage. Ultimately, that has not been the case. We wanted better health outcomes for parents and children by enrolling in the comprehensive health coverage provided by Medicaid. However, the results of the Secret Shopper study provide clear evidence that managed care organizations are not holding up their end of the bargain. About 1 in 8 calls in the study led to a disconnected number. For those who were able to connect with a provider, under 50% of those listed actually provided prenatal care or pregnancy-related care. After how many calls, rejections, or disconnected phone calls does someone decide to see if a medical concern just goes away on its own? Or they think to themselves, maybe a costly visit to the emergency department is my only option. This isn't a question we want our pregnant neighbors or family members to have to think about. It's the last thing we want them to have to think about during this very important time. These survey results are not just numbers on paper. It's a stark reminder of the urgent need for change. People who rely on Medicaid for health coverage deserve better. We implore the Department of Medical Assistance Services, state legislators, and the Youngkin administration to take immediate and decisive measures to ensure that our MCOs have a stronger provider network for the over 38,000 people who are in Medicaid right now, who are currently or were recently pregnant. And we know that there's going to be thousands more to come in the near future. We have to get this right for the next batch, because we already know that people that have coverage have issues getting appointments. we at the Healthcare for All Virginians Coalition will continue to fight for increased health coverage access and eligibility, with the expectation that with this clear evidence of the obstacles that Medicaid members face, Virginia will soon deliver the promise that health coverage offers. And with that, I will invite the founder and executive director of the Birth in Color, Kenda Sutton-L, to come up to speak.
Good morning, everybody. I'm Kenda Sutton-L, and I stand before you, proud Executive Director of Birth in Color. In addition to being a Black woman from the royal community of the Northern Neck, a mother who has faced challenges of the medical system not designed for my community, and also as a doula that's dedicated to the services and the countless hours to supporting pregnant individuals. I lead an organization that champions birth and maternal justice, representing a collective of over 250 doulas across the Commonwealth. And so before I go into the survey, we're going to have to be able to level set here. Because when you think about all of the statistics, the reports that come from our Commonwealth, we have to think about, what do these reporting say? It's a lack of access. It's they're not showing up to the prenatal visits, right? And so it's putting the blame on the clients. And so at this point in time, we have to be able to change that language. We have to start using language that's going to hold the states accountable. And so in the words of Dr. Scott, instead of saying Black women are 3 times more likely to die, we have to start using language such as, the system is actually murdering Black women at a 3 times higher rate, because in this system, it is not designed for us to really thrive. And so when you think about, I'm applying for Medicaid, is it the reason I'm not making it to my prenatal appointment because I don't know whether I really have Medicaid? They're not answering my questions. They're not answering my calls. They're not giving me a return phone call. And so I'm not surprised by the survey results. Everyone else is, and they're like, oh, we can't believe that this report came out. But when you come to a Black woman who deal with other Black women to try to help them thrive, it's like, oh, that's what we've always been led with. That's what we've always had to do. And so this just validated the experiences of many black pregnant women in my community who tried to navigate the complex world of managed care organizations against a backdrop of significant disparities. We know that Black mothers are suffering and dying at a higher rate, particularly in areas that is limited to care. We know that experience higher rates of loss, pregnancy loss, and infant mortality. Both unconscious and conscious biases contribute significantly to these preventable tragedies. From the experiences of our clients and doulas, it is evident that obtaining quality prenatal and postpartum care is especially challenging for Black women, exacerbated for those on Medicaid. However, we can take and must take steps to address these issues. The report we are discussing today, alongside policy proposals supported by the PUSH Coalition, outlines critical and crucial improvements. The lack of timely access to care, the failure of so many providers to meet DMAS requirements for urgent visits, and the higher number of providers not accepting new patients or Medicaid, highlight deep-seated problems that require immediate attention. While this survey provides an overview of MCO shortcomings, further research is necessary to develop policy solutions targeting the root causes of preventable fetal and infant mortality, as well as maternal morbidity and mortality. One critical solution in the establishment of a robust fetal and infant mortality review team. We need to understand where and why individuals are falling through the cracks, and we need more than just quantitative data. A significant portion of fetal and infant deaths are actually preventable. Comprehensive data collection and analysis are essential to developing evidence-based, community-informed policies that address the root causes of these disparities. This involves the fetal infant mortality review team that goes beyond qualitative data and medical reports to include interviews with patients, providers, and community members, identifying necessary preventive measures and addressing gaps in care. It means focusing on underserved populations in areas of state, conducting deep dives, and proposing robust evidence-based policy improvements. It means understanding how much the fetal and infant mortality mentioned by other speakers is caused by the lack of access to timely prenatal and postpartum care. It means understanding which interventions is and will be the most effective, in which area of the state, and the ways the state, as well as advocates, providers, can best help patients navigate access to care issues before it's actually too late. Birth in Color remains committed to collaborating with our partners, our legislative champions, to drive a policy agenda that confronts racial disparities head-on. We aim to implement proven policies and explore innovative approaches because the unacceptable and preventable deaths of women and children, particularly Black women and children, in the Commonwealth demand urgent attention and action. Thank you. I will now turn it back over to Catherine to conclude.
The new MCO contract that DMAS released in its request for proposals in the fall has tremendous potential to address the concerns that were highlighted by the Prenatal Secret Shopper Survey and many of the speakers today. DMAS, thank you for this. The PUSH Coalition appreciates the emphasis in the new contract on community partners. The new contract requires MCOs to develop a health-related social needs plan with specific measurable objectives. It requires partnering with community-based organizations and utilizing community health workers and other care management extenders. The MCO must also provide community-based doula services, which is very exciting, as a covered service to address many of the drivers of poor maternal health and child health outcomes. In addition, as the midwife Nicole Wardlaw mentioned, it requires cultural competency and bias training, so kudos to the MCOs. The results of the Secret Shopper Survey compel us to call on MCOs to report publicly on a monthly basis to DMAS on how they are meeting the new requirement to partner with community-based organizations to address barriers to accessing maternal and infant health care. Better data informs better policymaking, and so we would like to see data on how this partnership increases access to midwives, community health workers, and doulas. We are also calling on the governor's administration to give their full support to DMAS to hold MCOs accountable, because it will require additional resources. We believe that the governor's blessing will amplify DMAS's ability to leverage the necessary resources to work together with all partners to ensure that all Medicaid-eligible Virginians have access to the prenatal care that they need. The intent of this press conference is not to attack MCOs. Virginia is ranked 25th for health outcomes and 22nd for clinical care, according to America's Health Rankings 2023 report. We are ranked the 19th healthiest state after Maryland, North Dakota, Iowa, and Nebraska, to name a few. We are ranked number 36 for public health funding, and we have a high prevalence of multiple chronic conditions. So MCOs have their job cut out for them. Our hope is that MCOs see this as an opportunity to advocate for legislation that they need to improve access. That might include Medicaid rate increases so we can compensate our providers appropriately and support to tackle our healthcare workforce shortage. Virginia moms, children, and families are counting on us, and together, Governor Youngkin, DMAS, MCOs, advocates, healthcare providers, we can make maternal health care access equitable to all. Thank you to everyone who showed up on a hot summer day. We appreciate your support. We know it's been a long agenda, but we wanted to send the message that this is a very large group. We couldn't have all 20 folks, or it's more than 20, more like 40 by now, but it sends a note of urgency when you see this broad support. We appreciate MCOs being in the room because that we see them as a committed partner. and appreciate Senator Bagby for coming in. We know that there have been many conflicts this morning for legislators. If I'm missing a legislative aide, please identify yourself now, because I would like to thank you for your presence. No. Well, thank you, Senator Bagby. We know you'll carry the word back. And now we have time for questions for folks in the audience.
Jim Dotson with Courthouse News. Could you explain a little further the problems with the data from the survey that BPM wrote about this morning?
So the problem was that in the methodology section, that the same methodology was used for the primary care survey. It was printed as the methodology for the Prenatal Secret Shopper Survey. So obviously, they didn't have the same methodology.
But it's y'all's position that that data is still useful regardless of that?
Yes, given the stories that I think providers that are out, I think probably Nicole Wardlaw, who is a midwife, you know, it's, you hear, I used to be a practicing midwife, and so I took calls saying that lack of access can be tough. And I think that we sometimes assume from our lens that, okay, they didn't answer my phone call, I'll just call them back. And we don't think that maybe the mom doesn't have a lunch break, right? Maybe she said she had to get something in her car and, you know, use that as cover to buy, you know, 2 minutes to quickly call a provider. I think we often make our assumptions and don't think probably everyone in this room has a lunch break, right? But that's not the case for everybody.
I know several people have said steps they want to see taken. I know there's stuff in the press release here, but can you just sort of recap? So you're talking about there's good steps in the new contract messaging, but apologies, what you wanted to see from the governor, from DPAS, from lawmakers to address this issue that's not already put in the report?
Well, we asked the governor for his blessing because that's how the system works. For example, Help Right Now, right? The governor brought attention to mental health, which can be a stigma, and that definitely directed a lot of resources to mental health and the addiction crisis. And so in that same note, we would love him to give us his blessing. We make it could look like a statement saying, you know, I would like to see funding increased for DMAS. I remember in the article that while and reference the article to get the quote exact, but the Medicaid funding has increased, but staff capacity has not increased to keep up with that funding, right? So DMAS has to manage, you know, if the funding increases by 10 million, you know, does an individual staff caseload just gets higher, and then they don't have the resources they need to do to get the work done. So we can't overlook what DMAS needs.
I know there was a maternal training, biased maternal training bill this session. How did that end up? Okay, just somebody want to give me something on?
It was vetoed. It was bipartisan. Everyone agreed. Oh, sorry.
Yeah, I'll let you take that.
So I will.
About what the bill was, and then.
So basically, what it was going to do was mandate that providers, when we had to relicense, that a part of our CMEs had to be implicit bias training. And it's not something new, that there are other states. As a matter of fact, I'm licensed in DC, and I had to do certain training in my CMEs for me to be licensed in, to be able to practice in DC. So that was supposed to be included in our renewals of our licensure. And I will say that it was bipartisan, that our legislators agreed that this is something that should be done, and our governor vetoed it. So it is not going to be a thing, but I feel like it needs to be a thing, and I would ask that the governor reassess his decision on that. And he vetoed it, if I'm not mistaken, because of certain language that was in it, that we talk about implicit bias training so that people can address racism. And as racism is clearly one of the issues that causes these disparities in the communities. And so that language was stricken. And then once we strike that and other language, I don't think that we liked having the term birthing people in the language. But there are birthing people and there are mothers, right? And when that was taken, then the legislators said, no, we can't do it this way. Either it's an all or none, but it was vetoed.
But they did pass and sign insurance coverage for doulas and
Insurance coverage for doulas, that was since 2021.
Private insurance.
Okay.
so this year.
That was the birthing color
So you guys are doing a lot, and I'm just trying to.
So the private insurance coverage bill was passed, but it has to be passed twice. So it was essentially it's referred to HERC.
Okay. Which one's her?
Health insurance.
Okay.
Yes.
Okay.
So HERC needs to take its final steps in evaluation, and then it has to pass again in this upcoming 2025 session, and then it will be implemented.
Okay. Was the reauthorization clause built in originally, or was that added by Youngkin?
It was already in there.
In the bill, because any private insurance mandate has to go through the HERC process because of the bill that was passed many years ago. So it's a process we're going to have to take.
Got it.
Adrienne McGibbon from BPM News. Been working with Henry on his reporting. You seem to be taking an amicable approach with your relationship with the MCOs. They declined individually to respond to our request for questions. Have you spoken with the MCOs, and have they had a response about the result of this survey, and what has their communications been with you about their hope for improvement?
So I did reach out to one of the MCOs because I think you mentioned amicable. We all have to work together on this, and you don't want to blindside your allies. And it's hard to be put on the hot seat. And a little personal background, I used to be on a school board in a very large county, and so I'm very familiar with, do we have to tell the public that kids who have a low socioeconomic status are not in the gifted programs, because that makes us feel uncomfortable? And I would say yes, we do, because if we don't share the sometimes very uncomfortable statistics, then we can't do better, right? Then I can't get additional funding to fix that problem. And so in terms of future conversations, that will come after this press conference, and that's part of why in our concluding remarks, we are looking now to the MCOs. What are some of the bills that you would like to see? Sometimes it can be hard to pass bills that address workforce shortages, because it can look like you're helping businesses over the people, but the reality is if we don't have doctors in rural areas, then we're going to have to help fund residency programs. We're going to have to have legislative solutions, and it's yes, perhaps it helps businesses, but it also helps that person who needs a doctor regardless of where they live, right? I think sometimes those bills can be harder to sell to the public because they can be read one way. So this can, I think, be a springboard for tackling some policy solutions that will drive real change, and we can work together.
So just to be clear, these MCOs are contractually obligated to provide prenatal care?
Yes.
And so why isn't a legal remedy being sought instead of going through the policy?
So I'm not an MCO expert or a DMS expert, and if there is a DMS person in the room, I would defer to them. They're within the contract. There are already penalties, and there's a Medicaid, a medical loss ratio. It's very complicated. That question needs to be directed to a Medicaid expert. Does that make sense? There are protections built in within the system.
So what are those protections being enforced?
I don't understand, to be honest. Medicaid access is very complicated, and so that, again, a Medicaid expert would need to answer that question. Any other questions for any of our coalition members? All right. Well, thank you so much. We really appreciate, and we hope that we get good press coverage when we are coming forth with legislation to drive change, because you can look forward to that from all of us here.